Well, I'd like to welcome everybody to the latest webinar presented by the CMT Association. My name is Rick Albert, and I co-moderate one of the support groups out here in California. Today's webinar is entitled Answering Your Questions, Bracing and Charcot-Marie-Tooth. We're very fortunate to have David Misener here to share his knowledge with us. Before I introduce him, I'd like to explain how the webinar works. Each of the attendees should see a large window on their screen displaying the first page of a slide presentation. David will advance the slides in that window as he speaks. You should also see a webinar dashboard window which contains a question area where you can type in questions during the webinar. Following his presentation, David will address those questions. You can also use the question area to address any concerns about the webinar, such as volume levels, window display problems, or whatever, to me while he's speaking. You should also see a small window next to the larger window that shows a video of David as he speaks. You can use a little slider button between those two windows to adjust the relative size of the two windows to your preference. The webinar is being recorded and will be archived at the CMTA website, which is cmtausa.org, under the Resources tab and on that website's front page. It'll take about a week before the recording is uploaded to the site, but once it's there, you'll be able to see the slides and the recorded video, as well as hopefully read a transcript of all that's said during the webinar. David Misener is an American board-certified Prosthetist and Orthotist who has been practicing in Albany, New York since 1998. He's one of the 3 owners of Clinical Prosthetics and Orthotics, which has offices in office locations ranging from Saratoga Springs to Poughkeepsie, New York. Originally from Guelph, Ontario, he received his Bachelor of Science in Human Kinetics from the University of Guelph. He then went on to postgraduate work in Orthotics and Prosthetics at George Brown College in Toronto, Ontario. Not only does David provide services to people with CMT, but he also has CMT. He was born with it, as was his son, Ethan. He looks forward to contributing to the CMTA and is excited to be part of this great team. With that, I'd like to turn it over to David and remind everybody that they can present or submit questions to me using that question window. And at the end of the presentation, David will address those questions. With that, I'd like to introduce David. Thanks very much.
Thank you very much, Rick. I appreciate being here, and again, I'll apologize for some of this technical difficulties, so hopefully that will be the end of it, and we can move forward nice and smoothly. Rick did a nice job in introducing me. I think one of the key things is that I do have CMT, so I come at this from a couple different angles. One as an orthotist, but certainly also as someone who has CMT and who experiences CMT and who's a father and a son with individuals with CMT. I love this little tag that I stumbled across when I was surfing the internet. Keep calm and stumble along. And I think that says a lot about my life and how I move forward. So I think hopefully a lot of you can see the positives in that as well. When it comes to this presentation, I really want to extend a huge thanks to some contributors to this. Many of you might know Sean McHale's name. He's also an advisory board member to the CMT Association. When we create these presentations and present around the country, a lot of collaboration seems to occur, and I'm not exactly certain how much of this I created and how much came from Sean. But I do know a huge portion of this came from Ken Cornell. He's also an orthotist in Massachusetts. I put his name there because he certainly is an excellent orthotist, very knowledgeable about CMT. And that's the key, is to find some of these folks who are certainly knowledgeable about it. So we'll see. I'll advance my slides here, hopefully. Okay, the purpose of this presentation, as I see it, is I'm here as an expert, as an orthotist. So I'm going to try to come at it from the angle of an orthotist. I'm going to give you a brief description of CMT, You may have all heard a lot of information, and we all have access to the internet, so I'll just lightly touch upon, I think, some of the important factors that I see. So I'll give you a little bit of history. From an orthotist, it's good for you to understand the disease process, which includes the pathophysiology, the pathomechanics, and the critical insights into best orthotic designs. So some of those words may be new to you, pathomechanics. All that really defined is the mechanism behind something as it relates to bracing. And patho just refers to maybe an incorrect way that something might be occurring. So as an orthotist, the key is to complete a patient evaluation and then to discuss the orthotic management options. So the history. So CMT was first submitted or written in 1886, and I love history, and it's somewhat hard to find some of these individuals online, but there's a picture of Dr. Charcot. Here's a picture of Pierre Marie, and finally it was hard again to find a picture of Dr. Tooth, but these are the three physicians for where the name became. And I think we've all experienced Dr. Tooth as being somewhat of a challenge to the name of Charcot-Marie-Tooth, because they all ask us how our teeth are. Well, for me, that was even more so because my father was a dentist, and I grew up in a small town, so people really couldn't seem to understand why on earth I had a disease that affected my teeth and made me walk a little bit different. When you're doing your internet research, you can generally find some other names too. So peroneal muscular atrophy, hereditary motor sensory neuropathy, Charcot-Marie-Tooth Hoffman, Tooth's motor sensory neuropathy. I think the CMT Association is really doing a great job at trying to just push forward with this one name, although you certainly might be able to find a whole host of other names going along with the condition. So a description, it is a progressive inherited neuropathy that is characterized by motor and sensory loss. So we know that motor is the muscles and sensory is how we feel. And it's predominantly in the feet and legs, but it also can be in the hands and arms. And throughout this presentation, you will likely see my hands. I'm going to try to lift up some displays for us today, and you can see that I've got a pretty strong involvement in my upper extremity as well. So the proportion of CMT, there are differences. There's the demyelinating type, which is CMT type 1, and type 2 is axonal degeneration. And there are some differences in how they present. And again, when you're looking online, when you're gathering information, you need to be careful with what you're looking at and whether it's been properly defined. Currently, there's about 80 different types of genetic Charcot-Marie-Tooth, and that number is just increasing, I think, daily or monthly. So how do we find out? Typically, you're going to go to your neurologist, and they're going to do some EMG studies. And it's the speed of which the signals travel is what's going to define as to whether it's demyelinating or axonal degeneration. I'm not going to go into too much detail here, but again, there are significant differences in how CMT presents based on the type of CMT that you have. These EMG studies and testing is important to do for you or for your family. Just to try to know exactly what you have, what you might potentially be dealing with. And it also can narrow down what kind of blood work that could be done to find out specifically where the genetic error may in fact be. Some of the great things about CMT is that it generally does not affect longevity. This is a picture of myself and Ethan. We're both playing some basketball at home. CMT primarily affects below your elbows and your knees. It certainly can have effects going up a little bit higher, but it's usually less of an effect. And, this is a question. Can you predict the severity of it? maybe you can. For many families, you can. You can look at your grandparents, or you can look at yourself and maybe reflect on your child. Now, that's not always going to be the case. There certainly are times when you're going to see a child or a parent who is so much more involved with the condition, and this just speaks volumes to how much more we all need to learn about CMT. I'd like to think that CMT can be managed well, and I think it's part of these webinars and the CMT Association that's really trying to educate folks. Not only do we need to educate the practitioners such as myself, but the patients. And ultimately, it's going to become driven from you as far as how well you can manage yourself as well. So we want to arm you with some information. So when a patient comes in to see me, where does it start? Generally it starts with a discussion, and I'll hear comments that I have, or someone has general foot weakness, and it's typically known as a drop foot or foot slap. You might complain of an unsteady gait with some poor balance, or you might have a history of chronic lateral, which is twisting your ankle, sprains. Numbness, so it's known technically as glove and stocking hypothesia. So that sensation that's in your legs, you can feel a lot less. In your hands, atrophy of the hand muscles. You may have a weak opposing thumb. So whether you can move your thumb, I can't see my own picture there, but if you can move your thumb that's called opposition. So weaknesses in your hands, and you might be complaining about dropping things. So these are all important things that an orthotist should be collecting from you to sort of learn and start thinking about how am I going to be designing the system. A lot of the complaints might be the atrophy in your leg muscles. Your legs could be looking smaller than what you once remembered. Your toes. A lot of people will incorrectly define this as hammer toes, but more correctly it's called claw toes because it's folding or bending it at both of the joints. You might be complaining about some painful callousing, and typically we see that on the base and the head of the fifth, so that's the little toe, the fifth metatarsal. But it's also on the first. So I'm going to maybe lift up this foot every once in a while. So the first metatarsal is your big toe. So typically people might call that the ball of your foot. But then also the base of your fifth metatarsal. The base is here and the head is here. Part of our evaluation is to develop or get a history from you. So what do you do? What are your present activities? What are your desired activities? What are the complaints that you have? What is it that is hard to do, and what limits you? What would you like to do? These are all just very important questions that you need to feel comfortable asking, and we as an orthotist need to be also encouraging you to give these responses as well. So are the complaints weakness, or instability, balance, reduced activity levels? This all ends up being quite personal to every individual. So the assessment is also going to include sensory testing. So that's feeling the bottom of your foot, feeling the top of your foot, going up the leg. Where do I start to get a response from you that you can have what might be quote-unquote normal feeling? For many of us, it's at our knees. Testing the range of motion. So that is a significant player in this, and I'm going to be showing a whole series of photos in the future of this presentation that really is important in designing any kind of device. So range of motion is how the foot moves. So you can see this is typically what we would call the ankle joint. So can this go up correctly? Can it move through its normal range of motion? Doing manual muscle tests. So I want to get a sense from you, how strong are your muscles? Can you lift up your foot? And can you push against me? If I put my hand on top of your foot, can you lift it up? For some, these muscles become weak with a lot of exercise or a lot of walking, while others, they're not able to even overpower the weight of the foot, and it just drops down. And that's technically a flaccid foot or a complete drop foot. So, that's right now I'm considering how strong is your foot when it pushes up. But the other significant piece is how hard can you push against me? How well can you push off? And so that is needed at toe off at the end of the gait cycle. So watching you walk, your gait deviations, what are you doing to compensate? It's important for me to watch you and to see what you do. What's your balance like? Are you hanging on to a cane? Are you hanging on to an individual? Are you hanging on to the wall as you walk down the hall? How quickly do you walk? And do things change as you speed your gait? So this all comes full circle, and when we're at the point where we're asking you questions, we're explaining, we're discussing, and we're agreeing on a plan. And this goes both ways. I want you as the individual, as the patient, client, CMT individual, who you need to do all of this to me as well. I'm going to ask of it of you, and I think you should expect it of anyone who you talk to as well. We want the specifics on what you want. Every device is so unique, and in many ways there's not a right or a wrong answer. There are goals that we can plan on, but the last thing I want, or any orthotist would like to see, is the device sitting in your closet. And typically that happens when we really didn't do a thorough agreement on what we're doing. So I need to describe what a lot of orthotic options are, and there's many different ways to solve a problem when it comes to bracing. You need to be on board with moving forward with what we decide. And I like using the computer right in front of me, right in the patient room. I can show pictures. And I often have displays that I can show. And again, if you have a good expectation on what you're going to receive, then I think there's going to be a better outcome. So we want to agree on a treatment plan. Goals. What can we achieve? Well, the traditional orthotic goals are to prevent deformity, support and align your skeletal structures, limit or enhance motion about a specific joint. So those are the traditional orthotic goals. But I think a lot of stuff that's important for us in CMT is our balance. Can we improve the balance? Can we improve, can the device support us, allow us to do more? So reduce fatigue to some of the muscles. These are some key pieces to some of the designs that I'll be talking about in this presentation. So I guess you having a good understanding on the specific sequence of the muscle loss, of the muscle imbalances, which over time develop into the classic CMT deformities. So both of these pictures are pretty classic pictures of a CMT foot. You've got the claw toes that you can see in both images. You have a plantar flexed first ray. So that's the ball of your foot. That is highlighted because that is a significant driver to this condition. So, again, I'm not positive in how well you can see this foot here if I'm holding it in the right position, but this is your first ray, so the ball of your foot. Typically what happens is this gets plantar flexed, so it gets pulled down by a particular muscle. Now what also happens is you can develop an anterior cavus foot. So that really high arch that you can see in that bottom picture, not only is that first ray plantar flexed, but the whole front of the foot is starting to work its way down towards the ground. Now there's also forefoot adduction at the mid-tarsal joint. So looking at the foot this way, this is adduction. So the foot works its way in this way. So these are all mechanical things that happen because of the muscle imbalances. The inverted rear foot with lateral instability. So all of us, we talk about twisting our ankles. A lot of that happens because of this plantar flexed first ray, which you'll see in the next slide. And then the big player is external rotation of the ankle and knee axis relative to the line of progression. So when this foot starts to really twist, it can really start to torque the whole lower body. So that's why I'll be talking so much about alignment and how important that is. So it's these small muscles, those intrinsic muscles, they're the first to go, leaving the long toe flexors unsupported, and that's what creates those claw toes. And I know some of this I'm going over quick, but I do know that this is a recorded presentation, and you'll be able to always go back and look at some of this stuff. And I think from a timing perspective, I might just scoot past some of this as well. But I have laid out that the peroneus longus, that is the major player in which plantar flexes that first ray. So that's the muscle that really pulls down that first ray. Often what happens is if you don't use something, you lose it. So when that first ray is always being pulled down over time, what happens is you can't stretch it out. It can't come back. So that high arch just becomes so tight on the bottom of your foot that we're really no longer able to stretch it out. So we want to try to keep a lot of this stuff stretched out as you go along. I've shown you a good visual here. If you notice on, I guess, looking at the slide on the right side, you've got that light green arrow drawing, and it connects over to the ball of the foot. Well, that's the peroneus longus muscle, and that's what connects to the bottom of the foot. That is the driver of a lot of this forefoot problem that we have, and that's what drives the lateral instability. So this is a great slide that shows what's considered the tripod effect. So in static weight bearing, you get that rigid plantarflexed first ray, and you can see in that middle picture, the ball of the foot is pointing down, and that connects with the ground first. And if you can see that line that goes down the foot, that is a very neutral heel. Well, you can't stand like that. So what happens? Now you put weight and your body weight through your foot, and now you can see that line on that right diagram where that heel becomes tilted. So now your foot is completely on the ground and your heel is now tilted inward. That is what is called calcaneal varus. And that is all driven from that strong plantar flex first ray. So that's what we have to address. And one great way to assess it right in the lab, so the orthotist, if you're in a position where you have this lateral instability, your orthotist needs to find out how much posting do I need to put underneath your device, your foot orthotic or AFO, to stabilize that hindfoot. So if you notice this piece of foam, it's got that cutout where the ball of the foot is just hanging there. Well, in this case, you can see when you're looking at the heel that the ball of the foot is, well, again, hanging down there, but the heel is completely straight up and down. Well, for many of us, with that plantar flex first ray, we can completely neutralize that hindfoot. Now, if you go a long, long time, like even years, without that being corrected, we might not be able to get this complete full correction, but that's what we want to see. And that's what we as orthotists need to be assessing is, can we get you corrected? So this is some great photos showing from the heel, from the front, some classic characteristics of the deformity associated with CMT. Now looking at that foot, you see the claw toes, you see the heels completely tilted in. And you know what can happen is you can get to a point where if you're always in this position and you can't get the foot back into a more neutral position, then the bracing just becomes so much harder. And it is where I might be saying that surgery is recommended, to stretch out some of these tendons and ligaments and to get the foot in a better position. So I'm a huge advocate of starting bracing early, and it can be as simple as a foot orthosis to always maintain your normal range of motion. So what does your footprint say? You know, there's the normal foot. That's on the left side, the normal footprint. And then the pes cavus, If you're looking yourself at the sand, you can almost hardly see anything in that arch. So going all the way to the right is the pes cavus foot. All right, so I'm going to show you my footprint, and here it is. So the unique thing here is you're not going to see me too often walking around in my bare feet. And the reality is that I find wearing my shoes and braces so comfortable and empowering that I rarely go without them. And that's really where I want you guys to be. You know, if you're uncomfortable in your braces, then you need to get it changed. You know, we want to always maintain this range of motion so we really can have more simple bracing. And I can't stress that enough. We want to be proactive here. So I talked a little bit earlier about external rotary deformity, so ERD. If you can see on this child, that's actually my boy. That's Ethan. So if you can see, looking at his right foot is so much more externally rotated than his left foot. And what happens is the whole foot starts to rotate outwards. That heel is tilted in, but the knee is rotated outwards as well. And that can have a big effect on the knee and the hips. So it's really important to try to derotate all of this. You know, I think it's important to touch a little bit on hands. There's the classic hand deformity. That's a patient of mine. But at the bottom, you can see sort of the dorsum of my hand holding Ethan's hand, Ethan's foot in a neutral position. So I shall move on. I know that the cavus foot, that gets all the press. And I think it's important to note that it's not always going to happen. I'm not going to spend a lot of time talking about pes planus or internal rotary deformity, which is like flat feet. It's much less common with CMT, but it certainly does exist, and it certainly is worthwhile talking about as well. And I try to figure out, well, why does this happen? Why does one happen over the other? And I think there's not some good explanations as to why, but my gut feeling is that it might be created from a balanced or an equal weakness across the joints, as opposed to how I was speaking before about an imbalanced weakness that starts to pull things in certain ways. If you become weak in more of an equal way across the joints, I think this might traditionally be more of the presentation. So the normal path of pressure. So as an orthotist, we're always looking to try to get us back to what normal human locomotion is. Now, the center of gravity, the COG, it travels through a 2-inch square for maximum energy efficiency. So what that means is if you put a dot on our pelvis and you watched us walk, it moves up and down, side to side. And for a normal individual, it's about a 2-inch box. For a CMT individual, it could be a 4-inch box. Me, probably a 6-inch box. Who knows? But that's what our goal is to get us back to a normal biomechanical gait because it reduces fatigue. It just makes things so much more efficient. So the quality of the base of support. You know, if you have an abducted or an adducted forefoot, this will have an abnormal path of pressure. So in this picture, this is an adducted forefoot. So that's how that forefoot is drifting inward. If you look at the individual's, the orthotist's hands, I think this is Ken Cornell. If you look at his hands, that would much be the line of progression that he has on the heel. But look at how that foot is completely torqued inwards. So the path of progression is going to be much more over top of the 5th metatarsal instead of the 1st metatarsal. And if you really look at the skeleton here, the foot, you know, what is going to be able to tolerate a lot more pressure here? You know, do you think it's going to be the 1st metatarsal or the 5th metatarsal? If you look at the size of these, we are designed to get all the weight and to push off over here on this side of our foot. So that's what we as orthotists want to try to do, is get the foot to push off over here. In this case, the center of gravity will pass over the base and the head of the 5th metatarsal. So here's evidence. This is a great photo showing pressure points. Look at the extreme callousing that you see on the outside of the foot. So again, this is Ethan's feet, and so he's got intense callousing over that 5th metatarsal head. But he also has it on the base of the 5th metatarsal. What you can also see in these pictures is how high those arches are and where the body weight is where the pressure is going through the bottom of the foot. You know, the skin's going to always respond by trying to strengthen it, to try to prevent injury, and the skin sort of overdoes it. It over thickens itself and it creates calluses. Those calluses become hard and painful to stand on, and then the body actually tries to repair itself and it lays down more callusing, and so it's just a vicious cycle. Here's a great video. I've slowed this video down. I'm going to show this. It's an individual with CMT who is in this classic position. So we'll press play and let you watch. So you can see how she's completely over onto the lateral border of her foot. She's walked like this for such a long time, and you know, she gets along fantastic, great. But as she ages, you know, things become a little bit harder for her, and I would have loved to have seen her before these became so tight and the muscles are so hard to try to straighten and get into a neutral position. So I've got a picture of the profile as well. Now she seems to do not a too bad job getting those feet through without a huge drop of foot. When she wears her shoes, she does have, you know, more of that foot slap, but she's walking pretty great. But she's not comfortable at this point, and again, I'd love to see that kind of positioning, you know, not happening. So I've cast her for some custom AFOs. These need to be fairly strong and are going to try to correct her hind foot and correct her forefoot as well. So I've drawn a 90-degree angle on these casts. And for her foot to be in a fairly neutral position, and I need to get it there to try to reduce some of the forces that are going on the outsides of her feet because she's uncomfortable and it's painful. These are orthopedic pain. What I need to do is to get that foot in a much more neutral alignment, and you can see that that heel is now going to be up off the ground. And I need to get it in that position to try to reduce the forces that are on the body. So the one foot is going to require a heel lift on the brace, and the left foot is going to require pretty well this, you know, not quite as much, but I'm going to need to raise the whole foot about the equal amount just so I don't have her pelvis being unequal when she's walking. So it's a lot more bracing than I would love to do, but it's all I can do now to try to get her more comfortable and get her doing the stuff that she would like to do. So the question becomes, what options, what treatment options are there? Which design is right? You know, as I said at the beginning, there's no real right or wrong, but there are some goals that we should be meeting. There are some basic things that we at least should be aware of in what we're doing, and I'd like to say that you guys should be maybe be accepting of trying to get this neutral alignment and getting into a device that is going to allow you to be the best that you can be for the balance of your life. I think a good concept here is that the device is like a tool. You know, maybe one device isn't sufficient for you. Maybe it is. But if it's not, you know, if you think of a hammer and a wrench, you know, you can certainly put a nail in with a wrench, but it's going to be a lot easier using that hammer. And it's somewhat unfortunate that I think the whole payer system here in the United States, and certainly in Canada as well, is designed to just give one device. But that might not be the best plan for you, and that's, I think, a worthwhile discussion to have with your orthotist, or just, you know, with yourself. You know, do you want to do more than what one device can do for you? Maybe one device can't do it all, or maybe it can. The key here, what I've been talking about, is prevention. You know, start early. Start with a simple foot orthosis, or with an SMO, so that's a supramalleolar orthosis. You know, if you start simple with a foot orthotic, then you can start correcting that foot. Here's my boy quite early on. I could start to see he was getting tight at his ankle joint. So this muscle, all right? So this tendon was getting tight. So I held his foot in the most neutral position, and when he walked, we just passively stretched that tendon. And that was a big deal. You know, moving on in his life, he did need to have some surgery, and that surgery was a lot easier because he did have some joints that were had full and normal range of motion. I certainly couldn't do it all as an orthotist, and I needed to get some help, some surgical help. But with these devices, you know, you want to post the foot orthotic to prevent your lateral ankle instability, so twisting your ankle. If we build up the outside of that insert, it's going to make it harder for you to twist your ankle. That's a great starting point. You know, 4-foot varus posts. So if the front of your foot is contracted, then I need to give relief to that. These are simple concepts to make your foot in a much more neutral alignment. Stretching exercises to help prevent tight Achilles tendon and hamstrings. Those are key too. Exercise. A lot of this stuff to help us be the best that we can be. So here's some good pictures of some of these accommodative foot orthotics for fixed deformities. So that top picture is that lateral post. So do you see that thicker amount of material underneath the little toe? Well, that's the post I'm talking about. So in these bottom two pictures, you can see on the left side on that black foot orthotic, that was an orthosis made by, you know, an orthotist who really thought he was doing a great job by reducing some of the pressure to the forefoot, you know, and to reduce some of the calluses, but he ended up building up the arch to try to take pressure off of the callusing. But it did nothing to straighten the alignment, and it actually made him put more pressure along the outside of his foot. So if you look at the next picture over, that same foot on a foot orthotic that's posted along the outside gets that foot much more neutral, gets the weight-bearing pressures over the ball of the foot, and in turn reduces the amount of force on those calluses along the outside of his foot. So as we start to need more stability, you can get a lot more control about going up a little bit higher. Not only are we now underneath the foot, but we can start to control the foot. We can start to control the adduction of the foot. You know, it's a lot easier to do this in a younger foot, in a child's foot. So typically, this would be something, if I saw a young child with an adducted foot, I'd put her in one of these SMOs to try to straighten out that foot. We can do it in adults as well, but it's harder, and sometimes you have to put more forces on. But it still does increase stability, reduces the those lateral or the twisting your ankle kind of injuries. When we get to carbon off-the-shelf AFOs, I think these are fantastic for us. What's great about them is you can merge systems. The picture on the left shows the Allard toe-off system with a custom foot orthotic that goes on top of it. These off-the-shelf carbon AFOs, they are manufactured in a way that an orthotist can't do it in their traditional lab. They're made under intense heat and pressure, and these multiple layers of carbon get sandwiched together. That creates a very thin, lightweight, but energy-storing device. But it's also very dynamic, so we allow motion. We allow the foot and ankle to still work. In some cases, we can get away with just using a custom foot orthotic on top of the foot plate of the carbon AFO, or in the case of this young child here, I needed to put her into an SMO. And it's, I love the coloring that she selected here. You've got her socks, and you've got the Allard AFO with the pink covering and the heart, and then you've got my SMO at the bottom, which is another set of colors. I love it when individuals are just so comfortable with themselves that they just try to show off what they have. And I'm happy to also know that society has moved a long way in that direction too, so it makes things easier for us. So ground reaction and dorsiflexion assist. So the Allard system, it's the same picture. It does act as a ground reaction AFO. So what does that mean? Well, with that AFO in place, the foot plate is so strong. I'm going to move out of the picture here and grab one out of my bag here. So a ground reaction AFO. So this is, the ground hitting the front of this system. It's going to push on the knee up here. So that is what I would consider a ground reaction AFO. So that can give some stability to the knee. So if your quadriceps are starting to feel a little bit weak, these Allard systems as an off-the-shelf or this custom device can give strength to your quadriceps and can support your muscles. A dorsiflexion assist system. In the left picture, I have an AFO here that on one side, on the left side, they're wearing a rigid AFO, and on the right, it's a dorsiflexion assist. So that is just a simple type of joint that lifts up the foot, lifts the foot as you swing it through. And you can see a series of strapping on that that also is in place to hold the foot in a nice neutral alignment. Balance. It is always going to be secondary to your sensory deficit. So if you can't feel where you are in space, if you don't know what's going on, then it's hard for you to make those corrections. And that's the issue with CMT. If you don't have the feeling and the sensory input in your feet to tell your brain what to do with your muscles. And many times you'll find that we will walk along with our arm around someone or a finger on a wall or hanging on to a solid piece of furniture. And that in many ways is giving us some different type of sensory feedback. That's why the ground reaction AFO also works well, is we're raising the point of connection. So you now have something up around your knee that you can get a sense for where your body is in space, a little bit better than just underneath your foot. Custom energy storing AFOs. So if we need to start to get a little bit more control out of the foot and ankle, that's where we start considering these custom systems. And I did just lift up one here. I think a lot of us do research, and you can see online called the Fat Brace. Well, it is a great system. These are always custom made, and they're a little bit stronger than the Allard system, and it controls a lot more. So if your body is needing a little bit more stability to it, then if you think of a sliding scale of control, this would be the next pathway to get more control and more stability to allow you to, in turn, do more. Now, there are cases that we really need to de-rotate the body. So if you look at that foot, you can really see how it has that classic positioning. And that positioning is equal on both sides. So when you look at her foot inside that AFO, you can see how straighter the foot is. So that in its own right gives a lot of additional stability to your body if you can get the muscles and the bones to work in a proper alignment. So this AFO is certainly a lot bulkier, a lot bigger, but it's needed because of some of the positioning that we see here. What I'm doing here is just describing a lot of the intricate details into what is involved with this custom brace. And I'm going to just quickly pass over this based on timing here. Here's some nice pictures and some nice samples. We've got custom braces here, and we've got the Allard system with a custom foot orthotic on top. It's hard to know, again, what is the right or wrong answer for anyone. So the key is that we're meeting what your goals are. You may find that you just have you walk on a lot of uneven terrain, and you need some ankle support, ankle stability. That boots are just not doing it for you. Well, this device can work very well. We're not controlling any real dorsiflexion or plantar flexion. That's the foot going up and down. And what we're doing is just giving you great side-to-side support. I wore a device like this for quite a while when I was golfing, just because, you do this beautiful golf swing, and then I'd twist my ankle and fall afterwards. So I got tired of that, so I built myself a device like this that gave me that necessary support. And it was great. Here's just some additional photos of straightening out the foot within a device. So those straps that are harnessed down around the ankle, they're harnessed within the AFO. So it's directly connected to the body, to the AFO that comes across the body on the outside and then goes to the outside of the brace along the inside of the AFO. And what that tends to do is to straighten out the foot. So that's a good comparison there. The silicone AFOs, I think in my opinion, this is a great AFO for certain cases. This is an AFO that I wear. That's a picture of me. Why this, for me, is so great is I do a lot of water sports. If you notice, you wear your socks over top of these AFOs. So if you're the type of person that likes to take off their shoes inside their home and then you sort of feel that you can't walk very well, well, this is a great AFO because you can put your socks on over top of it and you can walk around in a much more stable position. I do have a custom foot orthoses within my shoes that get my foot into a neutral position. These are not going to be for everybody. You have to be able to get your foot in a nice neutral position to be able to use a device like this because it's very flexible. I would describe this as something that almost directs you as opposed to really controls you. So it definitely helps with a very mild drop foot. And I think the other reality is that as an orthotist or as some orthotists, they like to get 100% correction. Well, I don't necessarily know if we always have to have 100% correction. We should be able to key into your goals. If you're happy with an 80% correction and your foot swings through nicely during swing phase, but there's a slight little foot slap at heel strike, if that doesn't bother you, it's not going to bother me either. And this kind of system, I think, fits in that category well. Limit or enhance motion around some specific joints. So devices can get very complicated, and they need to get very complicated when we have lost range of motion, when we need to control the body a lot more. And that's what gets complicated with bracing is, you do need to try to reduce pain, increase stability, and it's always hard to know exactly how to do all of that and still fit it into a normal pair of shoes. And those are some of the discussions that you need to have early on as far as what your goals are. So the concept of maybe having one good leg to stand on, I think, is a fair concept too. You might find that being completely braced might make you feel just way too mechanical. So having one foot in a nice stable way and then give some flexibility to the other side, I think is a reasonable alternative too. Again, I'm always wanting to try to get a neutral alignment on both sides, and this is where the bracing just becomes so personal as far as what you are trying to achieve. So the more information you can present and describe it to an individual, I think the better the outcome is going to be. Balance. That's what we want to affect, and we want to improve our balance. And as I've mentioned many times here, just getting the center of gravity over the base of support, that's what's going to improve our balance. So if we have to have a really strong supportive device, then that's what you're going to need to have. But if you can get away with something smaller to achieve a lot of your goals, that's great too. And part of that process is getting into bracing early so you're always maintaining your range of motion to minimize what you need down the line. What else is there? So I think I've talked a lot about these lateral pretibial shells. That's an option, and what that can do is just give a lot more support to the outside of the foot. These are modifications made to really control feet that have really lost range of motion. So we have to apply so much more force to the body that we have to spread it out over a larger area. I talked about and showed you those casts earlier. Heel posts are going to be needed to accommodate a plantar flexion contracture. So if you notice in the right AFO, it's very thick underneath the heel. Well, that's to try to bring the ground up to the heel. And that's needed to get this individual to walk correctly. Everyone asks, do orthotics make CMT worse? Well, my emphatic answer would be no. I think that what we want to do is to always maintain range of motion. We want to, within the brace, allow you to be able to move your foot, to move your muscles. I think if you were completely locked up, like in a device that's like a ski boot, then yes, that is going to make your muscles worse. I think if anyone have broken a bone or you're in cast for 6 weeks, yes, your muscles are going to fatigue in a device like that. That's why we recommend devices that allow your foot to move, these dynamic systems. So that's what I want you to sort of get away, to walk away from this presentation, is to work your body, let it do as much as you can do. And I think that that is going to give you a great outcome. So some questions were submitted to me. So what I've done is I've added a few of these into the presentation. I think if others have questions, they can get those to Rick as we go throughout here. But I'm going to read these questions and I'm going to give answers. And hopefully some of you will be able to answer these in your own right based on what you've learned from my presentation. So the first question is, I'm an active person. However, in my current condition, if I walk for more than 5 minutes, my lower leg and thigh begin to really hurt. Will bracing make a difference for me? For example, being able to walk for longer periods of time without experiencing pain. Well, I hope you've learned that alignment is really important. So it's hard for me to know, is this individual aligned correctly? Could they have a lot less pain if they just had a simple foot orthotic where the foot is going to be aligned a lot better to get those muscles working in the orientation that the human body was designed to be in. So I asked the question, is it muscle fatigue? If it is, well, potentially the support of an AFO could help, because as long as we're allowing you to use your muscles and the muscles are going through their range of motion, using an AFO is not going to harm you at all. It's going to allow you to go further. I also ask, could this potentially be diet related? I don't know. Are you hydrated enough? Vitamins, your electrolytes, the calcium, sodium, and potassium levels. Those are issues that I think are important to look at as well. I think sometimes with CMT, these are common themes, and I think that you should get this checked out by a doctor to see if all of those are in balance, because that can also cause some of your pain. Okay, question 2. Is there a special brand or make of KFO for people with CMT? If so, what should I look for? I've just recently joined a support group in my area and found that the AFOs I was first using were a lot different than the ones worn by others in my group now. They say that theirs is what is recommended for people with CMT. That is what led to my question. I am on my second pair of KFOs, and they're somewhat different from each other. I have a very serious hyperextension of the knees, and they were measured to be at about 20 degrees. As of right now, I cannot stand in one spot with leaning on my crutches or something sturdy while wearing the KFOs. So getting back to your first question, I think we all try to not recommend specific brands, but rather concepts in bracing. And I think the key is to always to look for a knowledgeable and interested orthotist, someone who is going to really look at you and design something that's going to work for you. You know, I know that Ken is amazing, and I know that Sean is amazing, and I'd like to think I am. But I know another goal with the CMT Association is just try to maybe educate more practitioners out there, and we'd like to do that. And you know, I think that even though we're not recommending any out there, there are a lot of amazing folks out there. So as long as you are knowledgeable and come forward and asking good questions, I think that that can help foster a good relationship. So the reality is if you have a lot of hyperextension that you need, then you've probably spent a long time torquing that knee without bracing, and that knee has to get supported. And you need to have that straightened out. So I think some brief thoughts I had was to try to make it very lightweight, to maybe use carbon, and you want to be able to stand with stability and balance. So about trying to get that knee not as hyperextended, try to get yourself so you can stand stable. And you know, there are systems that are called stance control KFOs, that's in knee ankle foot orthoses. A stance control system is generally a system that is going to be able to bend when you're trying to swing your leg through, and then comes to a lock in full extension. Now you hyperextend. We don't want hyperextension, we just want full extension. So look into a stance control KFO. I think that it would be very difficult to walk with two straight legs if you were locked in position. So I think a stance control KFO is, I think, a good pathway for you. Or, you know, I guess there are other alternatives, but I could go on and on. Hopefully that's a good starting point for you. Question 3. I am not sure my braces are a good fit and serving the purpose for which I need. What should I do? Talk to your orthotist, I guess. I'm going to maybe just stop right at that point. Look for a knowledgeable and interested orthotist. Obviously, that's my theme there. Open communication. Listen and establish your goals together. I have a slight foot drop, but my biggest issue is the rolling of my right ankle. Even with my AFOs, the ankle is still rolling inside the brace. You know, you don't want that. You know, you need to have stability within the brace. That's the purpose of wearing the brace. You might find that you might have range of motion that has to be accommodated for. Maybe you do have a plantar flexion contracture, and when your foot gets completely neutralized, your heel is going to be up off the ground. Maybe you have to be posted a lot more than you really want to be posted. Those are things that need to be described to you, and you having a great understanding is what's going to, I think, maybe give you a better outcome. Are silicone AFOs a good option for CMT patients? How can I still be trendy in shoe choices as a young lady in AFOs? You know, I think the silicone AFOs are a great choice for CMT with patients. I wear them. But I also wear carbon AFOs, you know, at different times, because getting back to that, a device is like a tool. For the most part, I'll wear my silicone AFOs. Some days I'll wear one silicone AFO and one carbon AFO for some of that balance and stability. If I'm going to be at a conference and standing around a whole host of other people, I'm way better in a carbon set of AFOs. But the silicone AFOs, they will control that, that ankle instability, the rolling of your ankle, and I think they do a great job at that. If you have a very mild drop foot, I think the silicone AFO does a great job about that. And what I love about it as well is it really does allow full range of motion. So when I'm wearing them, I really don't know that I'm wearing them. I feel completely normal. My socks are over top. It's just hard. It's hard to tell you're wearing them, and I think they're great. Okay. Question 4. I have bilateral foot drop as well as my ankles roll. Diagnosis with CMT at age 12, and I am now 53. I have worn bilateral AFOs for the last 10 years and can barely walk without them. My AFOs are custom fit and made of Kevlar. I'm thinking of carbon fiber bracings. What are the benefits and disadvantages besides cost? Also, what do I look for in someone to give me a good fit with bracing? I've had problems with pain with custom bracing before fixing these. All right, so the first thing I want to distinguish here is custom fit versus custom made. You know, there's a subtle nuance there. Something that's custom fit, it's going to be like the Allard toe-off brace. That does need to be adjusted for proper use. None of those Allard systems are supposed to be just put on the patient and see you later. They need to be adjusted. You need to have standing stability in them. Typically, you put a heel post underneath the heel of the AFO. That's a custom fit device. Now, I've talked about a custom made device going on of that Allard system. So that's been made from a cast of your body. So the custom made portion is what's going to be married to the custom fit portion, and those together are going to work in harmony. So there's a definite difference. So it's hard for me to really know what you're wearing. You say a custom fit and made of Kevlar. When I think of Kevlar, I think of a material that's very flexible and strong, like canvas. So you could very well be wearing like some sort of ankle gauntlet. Maybe it was custom made. I'm not sure. Kevlar could also be used to laminate into a system. You know, and I think from Kinetic Research, there's the noodle. I think they use a combination of Kevlar and certainly carbon, but don't quote me on that. I'm not exactly certain of his manufacturing process, but Kevlar certainly can be laminated into a device when that is. So what does carbon fiber do? You know, it allows motion and it returns energy. It's very springy. The off-the-shelf carbon fiber systems are excellent at doing that just from the nature of their manufacturing process. When we manufacture them in our lab, typically the device is going to be lighter and stronger, but it's generally not going to be as effective as far as springiness, unless you are such a great lab and you've really dedicated a lot of time and effort into really knowing precisely how to lay up that material. And there are companies that even I would send my custom devices to, and that's, you know, the Fat Brace, there's Custom Composite. These are manufacturers that I would know as an orthotist, sending these casts to them for manufacture. And Kinetic Research manufacturing the noodle and a whole host of other devices that they have as well. But talk to your orthotist, and again, look for a knowledgeable and interested orthotist. You know, I can't stress that enough. You need to be comfortable in the device that you wear, or else you're not going to wear it and you're not going to do what you want to do. You need to have open communication, you know, listen and establish goals. And I think this is really important, is to take an active role in your treatment. You know, so often, you know, these devices, they don't meet all of your goals. But if you really are on board with knowing up front what you're going to achieve and what you can't achieve because of the decision that you may have made, then I think it's helpful for you understanding what's going on, because it's not easy making a good device for I think CMT individuals. You know, I know myself. I can play around with mine all the time, and I think that is that's what you should feel empowered to do as well. If it's not comfortable, get it fixed. Okay, this came from the CMTA online community that I happened to see yesterday, so I thought I'd add it here. I'm new to this site. Diagnosed with CMT in April of 2012. I have good mobility with my CMT, only affecting my lower body. At my latest appointment, they suggested I get the Autoblock walk-on AFOs, as well as insole orthotics, which I'll be getting fit for tomorrow. I tried them on and actually liked them a lot, to my surprise. I was just curious if anyone else had any experience with these, and if so, how they like them long term, and if they have helped you in your everyday life or improvement in your walking. You know, I think those are a great system. They work well for very mild support. Autobox also has a stronger model that they've just recently released called the Reaction. That also is an excellent system, and it's a little bit stronger. And what it offers differently from the walk-on flex AFOs is it offers, you know, I think a better push-off at toe-off. Reaction is a little bit more in line with what you might see with the Allard systems as well. I was recently given a set from Autobot to test, and it's sort of neat being able to test some of these products because, you know, I can give positives and negatives on each one of the devices that I've worn, and I think it's just important for all of us to know that nothing is going to replace, you know, not having CMT, and all of these are devices that are there to help us for the reality of the way we are. So, you know, try different things, and you know, in the office of your orthotist, maybe try some of these different devices so you do have a different sense. I think it's great that you're getting the custom foot orthotic as well. I think this is key. You've seen through my presentation how important that is, and it seems like the orthotist you're working with is excellent and very knowledgeable, so I'm pleased to see that. Other excellent models that I think are good to talk about is, you know, the Allard toe-off and the Blue Rocker. The Blue Rocker being a little bit stronger than the traditional toe-off. I talked about kinetic research in the noodle and the other variations. Excellent systems too. And I think we get a lot of positive feedback from the CMT community. Okay, question 6. This looks like a big one. Maybe I won't fully read this one. I think people can certainly read this, and based on timing, I'm a little over an hour now, so people can always read this question, but you know, I talked again just about the Allard toe-off, the Blue Rocker, the Noodle, the Autobot Reaction. I think would all be excellent choices for this individual. Okay, when do I know I'm ready to wear leg braces? That's a great question. I thought the longer I exercise my legs without braces do the walking for me, and that is better for my muscles. Well, hopefully a lot of you can answer that question now. You know, I think that you know, you do want to always work those muscles and such, but you always want to do it in the correct orientation. So I asked the question, what's your range of motion like? You know, maybe a good indicator on when are you ready to wear leg braces. You know, are you tripping or falling or twisting your ankles? You know, if so, that alone can create some secondary issues that you really should avoid. Start with foot orthotics. Maintain your range of motion and use the device if you feel undue fatigue that is affecting what you want to accomplish for your activities of daily living. Use the device like a tool. And I would recommend that you have an evaluation sooner rather than later. Exercise, stretch, physical therapy, at what point, how often, etc. Great question. And I know that there are some physical therapists part of the advisory board, which I'm pretty certain they're going to be doing some of these webinars, so they'll directly talk on this. So look at the CMT and then in the future for those presentations. But my response is do it now. You know, and I think you need to be careful, you know, as far as not over-fatiguing your muscles, but exercise is great. You know, you should be doing something daily. And again, don't fatigue your muscles. Don't overdo it, but I think you need to be doing it. You know, we all need to be healthy. So that means your diet, that means your weight, that means what you're doing for exercise. All of this stuff, I think that being healthy is what we're all told to do for so many things. And I just think that it ends up being just so much more important for CMT as well. You know, I can speak to myself in that, you know, I am a very active and busy person, but I was really starting to sense that going upstairs, I was starting to really try to push off a little bit more to try to get myself up that next stair, and I was, you know, getting worried about that. So I really started exercising on a recumbent bike, and I think those are low impact, and they really strengthen your core muscles in your legs, and just over a few months I noticed a huge difference. So that's one of the great things about the human body, is you can always strengthen it and stretch it out. Well, not always. Certain muscles may not stretch out, but some of these longer muscles, like your hamstrings and yoga. That is, I think, just a great exercise for any of us as well, because certainly it's about strengthening and range of motion. Okay, well, I guess that pretty well wraps it up. I loved finding this online too. When you stumble, make it part of the dance. And so I just want to thank everybody so much for, I guess, being here. And Rick, are you still there? And
yeah, hi David.
Okay.
I'd like to read half a dozen questions that came in during the presentation that perhaps you could
Okay.
First question is, I'm about to get my first pair of braces and I worry about investing in AFOs that end up sitting in the closet. How do I prepare? What questions should I ask the orthotist? What questions will be asked of me and what can I expect? I've read that not only is it important to see an orthotist familiar with CMT, but also to choose one who uses computerized gait motion analysis, scans, or pressure mats rather than just observation to ensure the best fit. Do you agree?
Well, there are lots of questions there, so at the very end, I'll answer that last question. I wouldn't agree with using pressure mats and with gait analysis as far as with fancy tools and such. I don't think that that's necessary. I think that those are just tools, tools of an orthotist that they can or cannot use or don't need to use. I think the most important things with your orthotist is being able to communicate with them, being able to talk to them, being able to let them know that something doesn't work and they need to have a willingness to make adjustments. To me, that is the most important thing, that communication. So did I answer most of what was there, Rick?
Yeah, the earlier part of the question was what questions should I ask the orthotist and what questions are likely to be asked of me. I know that in your presentation you went through pretty thoroughly what's likely to go on during the first or subsequent meetings. But as far as preparing, what might the person bring to the first meeting is probably a question that is still open.
Okay, well, I think it needs to be a goal. What are your goals? What are you trying to achieve? I think it is important that your orthotist has some experience with CMT, but I could also say that maybe in some rural areas you might have an orthotist that has not ever seen someone with CMT, and if they have good biomechanical knowledge, which I think an ABC certified orthotist would have, then as long as you can communicate with them and talk to them and they are making adjustments to your system afterwards, I think that those are the important things. I'm not sure if I think I've answered the question. Maybe my
yeah, I think that's pretty clear. Another question is what do you consider young? My son is 12 and we are just now considering bracing.
And so what was the question?
The question was, is age 12 too young for bracing?
No, absolutely not. I think that, a lot of these patients that I've shown you, I think CMT can be just so subtle, and I think that we all just go through life in some ways ignoring the CMT and almost not wanting to notice there's anything wrong with us, that we let little subtle things build upon itself. And it may take years before someone says, well, your range of motion is not good here. I think that bracing early, supporting the foot early, getting the foot in the correct alignment early is key, because that maintains your range of motion, that maintains the muscles in the correct orientation. So age is not a factor at all. You know, they could be at age 4 or 2, just when they're walking. You know, sometimes if you know your child has CMT and they're not walking, you know, at the age of 2, they might not be walking because they just don't have the stability around joints. And putting a device on them may give them enough stability to get up and going to start working on some of these other developmental milestones.
Here's another question that addresses the issue of orthotists that have experience with CMT. She says, I've had bad luck with orthotists. Much is because my insurance limits who I can see, and I've ended up with some who don't seem to really care. I'm beginning to rely on a scooter as my AFOs are so bad. I have my knees as my center of balance, but was told to watch over stressing them. They're still strong. How do I pick an orthotist?
Yeah, you know, that it's frustrating because, you know, the orthotist, we are limited by insurance carriers and Medicare, and you know, the guidelines that go along with a lot of this really complicate a lot of the fitting and the design of devices. You know, so my whole presentation was about mechanics, biomechanics, but you know, unfortunately for most, finances are a big key to this too. And when an insurance carrier says that they are not going to provide you with a particular device, your only option is to have to come up with it out of your own pocket. And for most of us, we can't afford some of these devices because they're expensive. So, you know, it's a hard position to be in, and I get that. I think that I think just trying to have that open communication going into it, talking to the individual, being able to communicate, and the practitioner being able to listen, and then you being able to listen as far as what the practitioner sees, and then establishing goals together is going to be I think the best course of action.
Is there
any... Rick, I don't know, I'd like you to review those questions to see if I'm answering them enough, or reread them for me to make sure I'm addressing all of it.
Yeah, I think you addressed that one. There's a follow-on question that kind of gets to the same area. That is whether there might exist a list of orthotists who are certified to treat patients with CMT, or have some sort of credential perhaps that would let a patient know that orthotist has the right kind of experience.
You know, it's we don't have that. The CMT Association hasn't done that, and I think it is difficult to do. So, you know, I don't know how to better advise on that. You know, you know, the same situation is going to be true for an orthopedist as well. If you went to an orthopedist, how do they know how do you know if they have experience with CMT, or your primary care physician? You know, it is about maybe you asking the questions and maybe feeling comfortable asking the questions, and if you're not getting the answers that you are wanting or feel are appropriate, then maybe go on to the next person. What I can say is that you know, there are, you know, I would look for an ABC certified orthotist. So that's an American board certified orthotist. That is the highest standard in the United States as far as baseline education. then that's not always going to be enough, because we all need continuing education. We all need to we develop our niche markets, and I think trying to find someone who at least has some exposure to it, or can look up CMT, and maybe that is the pathway to go down. Again, I guess for some reason I always seem to come back to this communication issue. If you're not able to talk to someone, then that creates problems. I think that any ABC certified practitioner has the tools to assess people with CMTs, and I get the fact that you might not always have someone, or you've had bad experiences. I know that happens, but I guess I don't. It's hard for me to understand why it happens, but I accept that it does, and I think it becomes your responsibility to maybe just go elsewhere, or if it's an insurance issue, is to complain to the insurance carrier about allowing you to see someone else. And maybe that just is not a reality, but it might be the only recourse.
I have a couple more questions that are specific to certain braces. The first one is, I've had an Allard and found no energy return from it. Where does the energy store come from in that brace?
Well, so it's hard to know if it's the toe off or it's the blue rocker, but when you deform the product, like bend it, that's when it bounces back. Let me see if I have one here. Now, I don't have an Allard with me, but this one flexes. So when this flexes, I'm pushing pretty darn hard here. So that is the spring that you get out of the system. Okay, so when you're walking, you need to be putting enough force into the toe to be able to push off. So if you're walking, enough spring to push off. So you get out of these dynamic systems what you put into it. So maybe the system you're wearing is not strong enough, and you're not able, maybe you're too heavy for a standard toe off and you need the blue rocker. Maybe the blue rocker is not strong enough and you need to go to a custom system. But maybe you're not walking fast enough, and you just might not get out of that system what it is designed to have built into the materials itself. If you're a very slow walker, just shuffling along, it might be hard to get that energy storing out of it.
We also had a question about the Helios orthosis. They say, I believe that it's an energy-loading graphite composite brace, but they don't know much about it.
Yeah, it is, and you can find the Helios online. It is custom made. It is carbon, and I think that the Helio is, if I'm recalling the correct company, it is a very pricey system as well, and I do believe that the fellow who designs them and markets them does a great job in producing a good AFO. But I'm not positive that you have to go to that kind of level or expense to get a good quality device. I think there's certainly, there's always people who are in the industry to do a great job and to get paid well for what they do, and I think that the Helio system is, I think that he's doing a pretty good job, but I think it's also maybe a little on the expensive side.
I think there's actually a lot of information online about Helios from people that have worn them, both good and bad. and probably could be found by using Google for that.
Yeah.
The final question that was submitted during the presentation also has to do with specific braces, and it reads, I have fat braces and love them. I'm still having trouble with the rotated foot and not getting it into neutral. I'd like to see something control the lower leg right above the ankle. With plastic AFOs, there were options with strapping and pads to do this. I can't seem to find a way to do this with the fat braces.
Yeah, it's, I do think that's an issue with the fat brace as well. I think you have to have a foot that's so much more neutral to really, for it to work well within the fat brace. I've talked to Noel about it, and, I think that what's going to happen with, let's say in your case, if you are really supinated, is I think the foot plate just needs to get trimmed down, like not the length, but the height, the way the fat brace, just the way it really wraps around the foot. I had a set of these made for myself, and Sean McHale made them for us. So he has tremendous experience with, working with Michael Shy and doing a lot of these systems that, even with Sean and myself working on it, I ended up needing to trim these fat braces all the way down so I could just drop my foot into it and not have these wraparounds. And then what I needed to do was to put my custom foot orthotic on top of the fat brace that had that lateral posting. So that's stuff that Noel and the fat brace just, they don't want to do that. Or I don't know if they've got a system that they have perfected, and it's a great energy storing system, and it really gives energy back. But I don't think that it's completely addressing some feet that might be a lot more supinated and need some additional posting built into the AFO. And the way the design wraps around, there's just not any room to do that. So you have to cut these wings off, remove them, put a custom foot orthotic on top, and then it can address some of those issues. If you need a lot more stability and control than that, and you really need some of the strapping that I showed previously with plastic AFOs, well, I still think that would be hard to do with this system because of just how flexible some of this material is. So that's where you might look into maybe a different carbon AFO made by a different company that is a little bit less proprietary. The fat brace is very specific. It's marketed and promoted as that particular device. You could very well find another custom-made device that stores energy very well that has maybe more of that control that you're looking for. But it would be much more in a custom-made model.
Thanks very much, David. I think we've exhausted all the questions and probably exhausted some of the attendees with our late start and very complete presentation. I think I speak for all of us in saying thank you very much for providing so much of your time.
Well, not a problem. Well, thank you.
And just to remind everybody that the presentation was recorded and will be up on the CMTAUSA.org website within a week or so for viewing by any attendees or anybody else that comes by that site. And we'll also have David's excellent slides available at the site as well. We'll probably have another webinar within the next month or so. Please keep your eye out for that, and everybody's welcome to attend that webinar when it happens. So thank you very much again, David. It's just very informative and great presentation about issues that are so important to everybody with CMT.
Okay, thanks, Rick. Appreciate it. Bye now.
Bye-bye, everybody.
To get a good quality device. I think there's certainly always people who are in the industry to do a great job and to get paid well for what they do, and I think that the Helio system is, I think that he's doing a pretty good job, but I think it's also maybe a little on the expensive side.
I think there's actually a lot of information online about Helios from people that have worn them, both
Yes.
good and bad, and probably could be found by using Google for that.
Yeah.
The final question that was submitted during the presentation also has to do with specific braces, and it reads, I have fat braces and love them. I'm still having trouble with the rotated foot and not getting it into neutral. I'd like to see something control the lower leg right above the ankle. With plastic AFOs, there were options with strapping and pads to do this. I can't seem to find a way to do this with the fat braces.
Yeah, it's I do think that's an issue with the fat brace as well. I think you have to have a foot that's so much more neutral to really, for it to work well within the fat brace. I've talked to Noel about it, and I think that what's going to happen with let's say in your case, if you are really supinated, is I think the foot plate just needs to get trimmed down, like not the length, but the height, the way the fat brace, just the way it really wraps around the foot. I had a set of these made for myself, and Sean McHale made them for us. So he has tremendous experience with, working with Michael Shy and doing a lot of these systems that, even with Sean and myself working on it, I ended up needing to trim these fat braces all the way down so I could just drop my foot into it and not have these wraparounds. And then what I needed to do was to put my custom foot orthotic on top of the fat brace that had that lateral posting. So that's stuff that Noel and the fat brace just, they don't want to do that. Or I don't know if they've got a system that they have perfected, and it's a great energy storing system, and it really gives energy back. But I don't think that it's completely addressing some feet that might be a lot more supinated and need some additional posting built into the AFO. And the way the design wraps around, there's just not any room to do that. So you have to cut these wings off, remove them, put a custom foot orthotic on top, and then it can address some of those issues. If you need a lot more stability and control than that, and you really need some of the strapping that I showed previously with plastic AFOs, well, I still think that would be hard to do with this system because of just how flexible some of this material is. So that's where you might look into, maybe a different carbon AFO made by a different company that is a little bit less proprietary. The fat brace is very specific. It's marketed and promoted as that particular device. You could very well find another custom-made device that stores energy very well that has maybe more of that control that you're looking for. But it would be much more in a custom-made model.
Thanks very much, David. I think we've exhausted all the questions and probably exhausted some of the attendees with our late start and very complete presentation. I think I speak for all of us in saying thank you very much for providing so much of your time.
Well, not a problem. Well, thank you.
And just to remind everybody that the presentation was recorded and will be up on the CMTAUSA.org website within a week or so for viewing by any attendees or anybody else that comes by that site. And we'll also have David's excellent slides available at the site as well. We'll probably have another webinar within the next month or so. Please keep your eye out for that, and everybody's welcome to attend that webinar when it happens. So thank you very much again, David. It's just very informative and great presentation about issues that are so important to everybody with CMT.
Okay, thanks, Rick. Appreciate it. Bye now.
Bye-bye, everybody.